And so what type of injuries do you usually see in women related to a dysfunctional pelvic floor?
I think the obvious ones, everyone knows kind of like leaking. I see a lot of prolapse, so like heaviness, pressure. Um, a lot of clients will feel like they're sitting on a ball. This is what I dealt with after my first pregnancy when I went back to running too soon. It's where the organs don't have the support that they need. And so it does feel heavy and like there's pressure and swelling down there. And so we can train the muscles to kind of help lift and support so that you don't feel that heaviness. The less obvious ones are like recurring low back pain, tailbone pain, a lot of hip injuries, groin strains, hamstring strains. Those recurrent muscle strains where you're kind of like, why is my hamstring always tweaked? Or why is my glute tendon always really irritated?
Hello, and welcome to another episode of Find Your Fuel. I'm your host, Erin Martin, and today we sit down with Dr. Rachel Selman to talk about one of the most neglected parts of our bodies, the pelvic floor. Most of us throw out a wish and a prayer after having kids that will miraculously heal and don't give it a second thought when working out, even though athletes are far more likely to be affected by pelvic health conditions than non-athletes. We train for speed, strength, and endurance, but also forget that every single movement we make relies on a deep connection to our core and pelvis. Dr. Selman is a performance sports scientist, orthopedic and pelvic PT, and founder of Synthesis Physical Therapy. She's also the author of a new book, Floor It, which is a first of its kind guide to pelvic floor health specifically for athletes. And so today we go beyond the basics of Kegels, talking about reverse Kegels and what we can do if we're lifting or running. I have a lot of personal takeaways that I am going to be incorporating this week for myself personally when it comes to the pelvic floor. And so our conversation with Dr. Selman is your fuel for today.
I am a physical therapist and strength and conditioning coach. I started in what is probably considered more traditional physical therapy, so very orthopedic, sports minded, lots of like working with ACL repairs, rotator cuff repairs, sports injuries, that kind of stuff. And then I got pregnant and was really disappointed by how much information was out there that all contradicted each other. And so there was a bunch of like blurbs and thoughts that were present at the time. So this was 2017. And so there were lots of thoughts, and it depended on who you asked, whether it was like OBGYN or personal trainers or physical therapists. Everyone had something different in terms of what was safe and what was not. I, of course, went along with what my OBGYN said because that was my medical provider, and I want to do what's safe for me and baby. At the time, the recommendations were no heart rate above 140, don't lift more than 25 pounds, no core work, all the kind of very conservative stuff. So I followed that, but I was very active before pregnancy. And so going from that level to following these very conservative guidelines, I lost a ton of strength. I lost a ton of endurance. And at the time, I thought it was just, doing what was best for me and for baby. Now we know that none of that is true. But then I got frustrated after pregnancy and postpartum because after I had the baby, then it became wild, wild west of like, okay, baby's out of your body. You can do whatever you want, whenever you want. So it was very regimented, check in with the doctor, talk to the doctor, check in and in-person appointments like all the time in pregnancy. And then postpartum, it was kind of like, we don't care. Like whatever you want to do, just go for it. Listen to your body, which I think truthfully is such bad advice for women who have been historically kind of like neglected by the medical system because we are really good at like ignoring pain, ignoring symptoms, pushing through things we shouldn't be pushing through when no one tells us otherwise. And so ended up with a lot of symptoms in postpartum that I think I would not have had to deal with had I had the education that I do now, and worked through all those symptoms with PT on my own. Now don't have any symptoms, but I understand how lucky I was to know that pelvic PT was even a thing. And now, jokingly, my husband says it's like my whole personality because I have turned it into this like, it's rehab for me to see women not have to go through what I went through, to have all of this guidance of you can do this and you can get back to this. And here's a general idea of what I would expect for XYZ versus overcautious, over monitoring in pregnancy. And then as soon as you have your baby, do whatever you want, whenever you want. So that's kind of how I ended up where I'm at now in the pregnancy and postpartum space. And that has slowly shifted even into just more athlete care, recreational, elite, really trying to help people understand that the pelvic floor is not a muscle group that is isolated to pregnant postpartum women. It applies to every single person, male, female, kids, no kids. It would be the same thing as me kind of ignoring a quad in someone just because they're a guy. Like, they have those muscles too. And we know from the research, the little research we do have, that athletes are more prone to pelvic floor dysfunction, regardless of if they have children or not. I say all the time, my job now is like pulling people out of the river. And I would really like to stop people from falling in the first place. And so that's kind of where I'm at this season of my career is, can we be more preventative and proactive about this?
Yes. And I think especially there's just this wave, probably our generation and before us, who did not have support. And so now I think one thing you talk about a lot is just how all other injuries in your body can be related to the pelvic floor. So it's like, okay, we have ignored this or known about it, but not really known what to do for so long. And then later on, after kids 40, 50, 60, we've got injuries or different things happening, and it actually is related to the pelvic floor. So I'm also curious, as a background, can you explain the pelvic floor a little bit more? Because I am not going to lie, before this, if I had to recap what the pelvic floor was, I would say it's your undercarriage and probably like the space just in between like the bottom of your bottom. Like that is it. Like that would be my definition of it, which is incorrect. And there's more to it. There's a lot going on down there.
I was gonna say that sounds pretty good. I've definitely heard worse. So the pelvic floor is a group of muscles. It can be anywhere. It depends on who you ask, because some people include some muscles of the pelvic wall in the pelvic floor. So let's just say like 9 to 13 muscles. It's a group of muscles, and it goes from the front, that pubic bone in the front of your pelvis that you can kind of feel if you press on the front, underneath, like you said, to all of those openings for women or underneath for men, and then to the tailbone. So it sits kind of like a hammock from front to back. So I tell people, if I take my palm and like put it under and between my legs, that's where the pelvic floor is. So it sits like a hammock at the bottom of our pelvis, and it has really big jobs like holding up our organs, managing pressure. It helps support the hips and the core and the back. So those are all very closely related. For a lot of what I work with again, recreational athletes, is it helps absorb force. And so when I'm doing tasks that require force, like running or lifting or cough, laugh, sneeze, all of those things, we have to be able to distribute force. And if we can't, something's going to do it. And so if the pelvic floor has some give to it, if it's able to relax and contract and do that on demand and match the actual demand that's necessary, then I don't see an overflow of force into the hips and the low back and the discs and all those types of things. And so I want the pelvic floor to be able to move, but I want it to be able to move in a controlled way. I don't want it to be something that's like a light switch where it's on off. I want it to be more like dimmer light. Like, hey, I need an 8 out of 10 when I cough, but I need a 3 out of 10 when I go from sitting to standing. And so I don't need a 10 out of 10 every time I go to standing, right? And if I do that every single time, when I actually do need a 10 out of 10, it's not going to be available to me because I'm doing that at times that I shouldn't be. And so, just like again, all of our other muscles, we expect them, we expect the knee to fully bend and fully extend to be able to control that range back and forth versus just full extension, full flexion. We need the pelvic floor to do that too, but it moves a little differently. Kind of like a trampoline. I want the trampoline to have springs that have enough give so that when I jump, there's some downward excursion. And I want those springs to have enough recoil that they bounce me back up. If the springs don't have enough recoil and I jump, I just keep sinking and there's nothing pulling me back up. If the springs are too tight and there's so much tension there, when I jump on that trampoline, it's very jarring. And there's a lot of, again, force to other areas that there shouldn't be. So I want those springs in my pelvic floor to have enough give to like lengthen when I need that length. But then I want them to be able to recoil and help distribute that force when needed as well. So both directions are incredibly important.
Yeah. And so what type of injuries do you usually see in women related to a dysfunctional pelvic floor?
I think the obvious ones, everyone knows kind of like leaking. Like leaking has come a really long way. Even with leaking, we used to like not realize that that was pelvic floor related. But I think most people now realize when they leak, that's probably a pelvic floor dysfunction issue. So leaking is the really obvious one. I see a lot of prolapse, so like heaviness, pressure. a lot of clients will feel like they're sitting on a ball. This is what I dealt with after my first pregnancy when I went back to running too soon. It's where the organs don't have the support that they need. And so it does feel heavy and like there's pressure and swelling down there. And so we can train the muscles to kind of help lift and support so that you don't feel that heaviness. So I dealt with that and I see a lot of that. The less obvious ones are like recurring low back pain, tailbone pain. So there's three muscles that attach directly to the tailbone. So if we have tailbone pain and it's not resolved with traditional physical therapy, a lot of times we just didn't hit the pelvic floor. A lot of hip injuries. So things like labral tears, groin strains, hamstring strains, those recurrent muscle strains where you're kind of like, why is my hamstring always tweaked? Or why is my glute tendon always really irritated? Sometimes that can present like bursitis, but to me, it's usually more of a glute tendon issue. Tendons are interesting, and they, I think, are just so slow to respond to training. Doesn't mean that they don't, but they're slower to respond. So the muscles respond a little more quickly. We train the muscles by a lot. Tendons take a while to catch up. And so I feel like they usually end up kind of being the ones that send this signal of like, hey, pay attention to me. And so if the pelvic floor is not doing a great job, we tend to see a lot of like tendinopathy, tendon cases, and issues. Now, I say all of that, and to clarify, we don't have research on that. You know what I mean? Like, there's not going to be a paper where you read and it says, oh, if your pelvic floor is dysfunctional, you're this much more likely to experience tendon dysfunction. I can tell you clinically that that's what I see in 10 years of practice. But if you go search for a research study, you're not going to find one that says X equals Y. I hope that that comes out in the future so that we can be better about treating these things. But I can tell you again, having worked before, in just regular, quote, regular PT, there are probably so many cases that I technically mistreated. And maybe they made some progress, but not full resolution. Or maybe we didn't get resolution. They ended up doing, an injection or surgery. And it's potentially because I didn't integrate the pelvic floor into their training. And so I hope that it's something that with time, the clinical patterns that we see will be further researched, which will give us more backing to like integrate this on a more regular level.
And just a sidebar on the tendon piece, real quick. That is one area where I started lifting heavy this past year and didn't realize a lot of what I was feeling and the soreness in joints was my tendons, not actually getting older or joint pain or anything. I was like, oh, I need to actually build strength in my tendons.
Yeah.
So just tendons being this whole other thing on top of muscles to work is kind of wild. And do you approach that in any different way, or is it just folded into the pelvic floor training and rehab that you do?
I approach it differently. Isometrics are something that there's been a lot of chatter about in the rehab space lately, which I think is incredible. Tendons love load. And so we actually like don't even use, or we try not to use the word tendonitis anymore. Because tendons, from what we can tell, don't really get inflamed. They actually change structure. So instead of them just being irritated and inflamed, where you could just take an Advil and it goes away, the tendon itself is actually changing structure. So we call it a tendinopathy, which means a literal change in the condition of the tendon. And so when you're experiencing something like tendon pain, the tendon itself, instead of being, like a nice organized rope, has started to almost like fray a little bit. And again, you can have a really strong glute or quad or hamstring, and the tendon just didn't get what it needed to catch up. And so you're like, I am lifting more, I'm doing more, I'm stronger. Where is this pain coming from? And the tendon just hasn't had the input that it needs to keep up with your muscle. So it's usually just a mismatch. Tendons love load and they love prolonged load. So isometric holds where, we are moving an immovable object and holding that for 30 to 45 seconds. Um, I love this for runners too, because it's actually not very fatiguing to your muscles. So, like if you're running and you're experiencing tendon pain, but you don't want to sacrifice your runs from being sore from lifting, we can do a lot of tendon work and still get really strong, springy tendons without, having you be sore and down and out for 2, 3 days. Where, sometimes with lifting, the reality is we are sore and it does compromise the quality of our runs. So, tendons love load, and isometrics have a really big role in that. The other thing that has been really interesting with tendon health lately in the world that I work in is that we're acknowledging now that tendon health changes with hormone changes. So, like with perimenopause, for example, which is up to
Mm.
10 years before menopause, we if they call it like the zone of chaos, where like 1 month your estrogen's fine, the next it's not, the next month it's like, kind of there. And so it's just very up down for 10 years. And then postmenopause, estrogen is low and stays low. In a lot of ways, it's actually kind of easier on our body when it just stays low because it's not that chaotic up, down, up, down. So the 10 years
We're not
before
riding a roller
menopause,
coaster.
yes, the 10 years before menopause is very unpredictable. And that unpredictability makes it difficult to kind of like judge what's going on in our tendons. So tendons have estrogen receptors. And when our estrogen starts to fall, we do see a decreased quality in tendon health. And so it's actually now called the musculoskeletal syndrome of menopause. Should probably be perimenopause, but musculoskeletal syndrome of menopause. So if I have a client who is, let's say, a recreational runner, raising a family, she's in her late 30s, early 40s, it's something where I might sit down if we're noticing tendon pain that's recurrent or is covering multiple tendons. That to me is more of a systemic issue where it's not just this particular tendon is problematic because you've overloaded it. Now we're seeing this not resolve the way I would expect it to, or it's my patellar tendon and it's my biceps tendon and it's a bunch of tendons at one time that keep kind of flaring up. That's where we would have that discussion of like, okay, could we get some estrogen on board potentially? And more doctors are willing to have that discussion. There's a lot of doctors that are very behind on that, but I can do all the work in the world on the tendon if it doesn't have what it needs from the body, whether that's through nutrition or hormone replacement or whatever it is. I'm only going to get so far. And so that is, I always tell people that's not my scope of practice, but it is my job to understand how they are affected so that I can refer out when I need to. And that doesn't always mean like refer out, I'm not going to work with you. It means I want what I'm doing to actually be able to do its job. And so if we do that with someone who's qualified in that area, then we're going to see better results. So just knowing that those tendons, yes, they're affected by the pelvic floor, but especially, if we're in that certain age range, we're approaching perimenopause, menopause, knowing that estrogen and the chaos that comes with that has a big role in tendon health too.
The joys of perimenopause just don't stop coming. And one thing you mentioned with the isometric holds then, what specifically type of movements or isometric holds could people do to work on tendons then?
Yeah, so it depends on like if you're having pain in a specific tendon, then obviously you're going to want to bias your training towards that tendon. So like let's say that I've got an Achilles tendinopathy where my Achilles tendon is just really ticked off. In those cases, I want to do some really heavy heel raises, which again sounds like the total opposite because it's not rest, ice, compress, elevate. It's load it and I want heat. I want to heat it after I'm done if possible. So I will, for example, get under a barbell, take the barbell off and put it under the J hooks or under an immovable object. And then I'll calf raise to where my heels are off the ground, but I'm pushing the barbell up, but I can't actually do the full heel raise. So I can lift my heels, I can generate force. I'm pushing my toes into the ground to activate my calf and Achilles, but I'm not actually moving. So I'm not sitting there cranking out tons and tons of reps because those reps are going to help the muscle. Not to say they don't help the tendon at all, but they're going to help the muscle get really strong. They still don't give the tendon much of a chance to catch up. And so getting under the bar, moving that, holding that, if an Achilles is a problem, then that's a great and easy one. I love the like Bulgarian split squat position where the front leg, I lift the heel and I'm really driving into the floor. Um, and sometimes I'll hold weights. You want it to be heavy. Like if it's not heavy and it's not challenging, it's not going to do a lot for the tendon. And so a lot of these tasks, we really want the weight to be, again, so much that you cannot do the actual rep, but you can activate and hold against it. If I'm working more on like the glutes, for example, I get the same barbell, get under the J hooks in a squat and push up into the barbell, into the J hooks so that I'm not actually moving, but I'm still connecting and activating my muscles. And that can help with reorganization of the collagen in the tendon. So that tendon that is frayed, it's us kind of taking those little frayed pieces and putting them back together and back in line. And then I usually will do that in combination with strength training because muscle training is obviously still incredibly important. So for me, it just depends on the day if I do it before or after training. I've had some glute tendon issues in the past. So like right now when I do my workouts I'm about to start a marathon training plan. I don't want that glute tendon to flare back up. So I'll do my normal lifting and then I'll finish with something like a star plank where I'm like driving that bottom foot into the ground, activating the glute on that bottom side, and I'm holding it for 30 to 45 seconds, 3 to 4 reps. I can do a split squat isometric, right? Where I go into a split squat. I'll take the barbell again under the J hooks and push into the split squat so that my front leg is activating. So you can kind of look up some of those like split squat isometric. Mid thigh pull is another great one for the glutes and hamstrings. If you've got hamstring tendinopathy, like lying on your back and doing that like bridge position, but with one leg, right? So again, making it very challenging, digging your heel into the ground, activating that hamstring tendon and holding for an extended period of time. Um, but it has to be heavy enough load to actually make the change, and it has to be a long enough load. The easiest way to think about it, what I describe to patients is like if I have a sponge that's really like full of water and junk, it's much more efficient for me to take it and squeeze it really, really hard and hold that squeeze for a very long time versus like doing a bunch of like little squeezes, right? I would take that sponge and wring it out and hold it there until all that fluid gets out. That's kind of what we have to do for the tendons because, again, they don't really have their own, this is oversimplified, but they don't have their own kind of like inflammatory markers. So we have to kind of like give them a little bit of extra help. So us doing those isometrics is kind of squeezing all that gunk out of there so that they can heal and can change and can be more efficient.
And this is the wild part of the pelvic floor to be because we learned about the pelvic floor and now we're on tendons. And so I think it can be so overwhelming for women on where to start as well. Like, especially just thinking about myself. I started lifting heavy. I love to run. So, kind of a hybrid athlete, mom trying to do a million things. And the thought of going in to a pelvic PT is probably a great idea and I need to do it. It's also a barrier for me to be able to do it. So is there anything that's like an at-home self-assessment that people can do to just get the lay of the land and understand the type of exercises or PT that they can fold in at home? Or what would you tell someone like me who's probably should, get themselves in, but also has limited time and is just looking for something that they could get themselves knowledgeable about their bodies themselves?
100%. So I think thing number one is that if the pelvic floor is working well, then your normal workouts probably already include the pelvic floor. You just don't realize it. So if you're not having symptoms, if you're not
Mm.
noticing, pain or problems, it's not something, even as someone who, wants everyone to be aware, I don't want to like make it the villain where like everyone on the planet has pelvic floor problems. If you're not having symptoms and you're feeling really good and your workouts are going really well, your pelvic floor is probably working fine. Again, the same way I don't really think much about my calves when I go to the gym. They just do what they need to do when they need to do it. I don't connect to them. I don't think about them too much. I just let them do their job. If we're not having symptoms, then the pelvic floor is probably doing an okay job. And your normal workouts will include the pelvic floor. So squats, lunges, even push-ups activate the pelvic floor because it activates the core so much, and the pelvic floor and the core work together. So if you're kind of listening or learning about this and you're kind of like, I feel pretty good, then there's probably no need to like go crazy and like try to then like pathologize everything that comes across our table because there's too many things, right? Between perimenopause and kids and life, there's too many things, and it, like you said, it can feel very overwhelming. So if you're not noticing symptoms, more than likely when you go work out, you are also working out your pelvic floor. If you start to notice symptoms and you're kind of like, I don't really know what's going on. One, of course, just professionally, I have to say, one-on-one nuanced care is number one. I am also a mom of kids. I'm also training for a marathon. I also own a business. And so I understand trying to find time for an appointment is not always doable for people. That is one of the big driving forces as to why I wrote the book, was because the resources when people would reach out and ask that same exact question were so limited. And so in writing the book, we worked really hard with the publisher. The publisher doesn't have pelvic health background. They have sports background, but they don't have public health background because there's just not very many of us, much less in publishing world. And so I would kind of write all my thoughts. She would take it and kind of frame it as like, okay, I as a general reader, general athlete, want this to be digestible too. And so the book itself is actually written to athletes, recreational, elite. It's written to you as an athlete. How can I learn about my body without overthinking and spiraling and making it feel like this is just one more thing I need to add to my plate. So the book was meant for that purpose. The book will also have like resources, like questionnaires that you can fill out that are kind of like, am I experiencing problems? Am I missing symptoms? Like a lot of people don't realize that feeling of needing to go to the bathroom when you start your workout is a pelvic floor dysfunction issue in most cases. So it kind of like pulls that to the front
Mm.
of like, are you experiencing these symptoms that maybe you didn't know were even pelvic floor problems? What severity are you experiencing them at? And then based on that, should I seek out a professional or is this something that I might be able to handle at home? So those questionnaires are kind of meant to help you just be aware, keep track. So, like again, you score yourself on those questionnaires. So, do I see my score going down with time, meaning that my symptoms are improving? Or is it going up with time as I enter perimenopause and realize that I maybe do need to pour into this a little bit more specifically? And those questions can go to your provider. So, like, here's the things I'm experiencing, here's how severe they are or are not, right? And so the scoring on that, I think we have it right now set to like 0 to 5 ish. It is kind of like a, hey, probably monitor, maybe make some adjustments, if you like can connect to those muscles in the way that we teach in the book. Try to do that in the training room a little bit more, work on your breath work on the basics, see if that integrates into your strength training. But using those types of tools to help people decide what's next. Because, like you said, I don't know, maybe I do have pelvic floor symptoms. I can't really tell. I don't really know what that means. I don't know if my hamstring strain is from my pelvic floor. Those questions, I mean, let's say that you also check the box that you have pain with sex or difficulty emptying or increased urgency. Then you're kind of like, more and more kind of indicators that maybe that hamstring strain has something to do with my pelvic floor versus just a plain old hamstring strain. So those resources in the book itself, that's what that was meant for, was because that question comes up regularly of I can't get in there. So like what can I learn something in the meantime? So I'm hopeful that that will help to start to bridge the gap a little bit.
Yeah, and is it mostly just looking at symptoms that you have in terms of identifying it, or is there anything physically too that we could feel to identify, either when we're lifting, running? You already talked about leakage, like some of those obvious ones. Is there anything else that comes to mind in the physical part that could cue us into, yes, maybe explore this more?
One of the things that we kind of outline in the book is to see if you can actually contract and relax. Because even when we say contract and relax the pelvic floor, a lot of people don't know what that
Mm.
means because they've never been taught. We hear the word Kegel all the time, but no one ever teaches you how to do a Kegel or what that actually means. And then the reverse Kegel, like, has no PR, right? Like, no one ever talks about that part. So the Kegel
I
is
don't know what that
just
is.
yeah. So, and for athletes, it's really your bigger point, the bigger thing that you need to know. So the Kegel is just a contraction. I feel like we're trying to move away from the word Kegel, but it's also so prevalent that Kegel is just the doctor who discovered the pelvic floor contraction. And so we don't call the biceps, a bicep curl by who discovered it. I don't know why we do it for the pelvic floor,
Yeah.
but a Kegel or a pelvic floor contraction, those are synonymous. And so sometimes I'll go back and forth between them just for, efficiency. So a Kegel is a lifting and a closing of the pelvic floor. Okay. And a reverse Kegel would be the opposite, which is just a lengthening. So the pelvic floor moves down and opens. So, for example, when we go to the bathroom, we have to do a reverse Kegel. We have to open and lengthen to let things out. So, if we have a client who's experiencing chronic constipation or needing to double void where they urinate and then they stand up and they think, kind of feel like I need to go again, we may have a difficulty with pelvic floor lengthening. And so, can you move in both directions is really a big foundational piece to me. You can check that at home. So, again, I have people like sit on their hand. So, put their hand under their butt, sit tall, and can I feel my pelvic floor lift up in the Kegel? And can I feel it push down in the reverse Kegel? Now, there's nuance. Again, my like professional disclaimer of just because you feel movement doesn't mean that it's perfect. But it's a way to start connecting. The diaphragm also works with the pelvic floor. So we can use our breath to connect to it a little bit easier. So when I exhale, and I blow out air, that's when the Kegel should happen. The lifting should happen. So as I am exhaling, like I'm blowing out a candle, I tell people to think about a puffer fish. So as it empties, the air comes out, the sides constrict, we feel a bracing in the core, but the bottom of that puffer fish is also going to lift up, right? So that's where that like bottom piece happens. When I inhale, again, going back to the puffer fish, the sides expand, but the bottom also falls. So when I take a really deep inhale, I should feel a lengthening and an opening of the pelvic floor. Honestly, one of the cues that works best is to breathe into your butthole. So as you breathe in, push that air kind of down towards the backside. I don't love the term push, especially when we're working with fairly active individuals, because when we say push, what I see is people just squeeze the crap out of their core. So, again, all the analogies, if I squeeze a tube of toothpaste and shoot the top off of it, yeah, goal accomplished, I got the top off. That doesn't mean that it was really the right way to go about it. I would like for us to be able to just slowly turn the top and get it off, without having to squeeze so hard that we force it. So, a true reverse Kegel or true pelvic floor lengthening should just be an opening. And those muscles can lengthen and stretch. And that's where most recreational athletes are stuck is they can Kegel and they've connected to that and they use it on a regular basis. They have a hard time going in the opposite direction. The challenge with that is if I'm stuck in a Kegel and I'm stuck in that contraction, when I go do a heavy deadlift or I go do a heavy squat and I need my pelvic floor to move with me, it can't. It's kind of stuck there. So it's going back to that trampoline example of we're tight, the springs are tense, I'm trying to jump and distribute force, and I'm just getting jarring, jarring, jarring. Here and there, not a big deal, right? If it's the end of a set, we're tired, we're fatigued. Okay, we're more resilient than that. We're not fragile. But if I do it over and over and over for multiple workouts over multiple years, that starts to add up a little bit. So I think at home, if you're kind of wondering, can I actually do this at all? Sitting on your hand, do I feel muscles move up and close as I exhale? And do I feel muscles move down and open as I inhale? And again, down the line, you can separate the two. We don't have to use the breath to make the pelvic floor move. But when you're trying to really exaggerate it to connect to it, I think the breath can be a really good tool. And visualizing, again, that puffer fish, like I expand, I lengthen, the bottom drops, I exhale, I contract, the bottom lifts. A lot of people have that backwards.
Yes. That 360 breathing, I completely had it backwards until I finally got it down and could practice. For whatever reason, it feels like rubbing my belly and patting my head. Like it's just hard to get down. But once you practice a ton, you can kind of get it. And I'm also thinking of tell me if this is right. I'm thinking of contracting and lengthening as an actual bicep muscle then. Like you're contracting and then you're
Hmm.
lengthening.
Yep.
But if you're running and lifting, you're contracting and lifting or contracting and lengthening with your pelvic floor while doing another movement, which can make it something you need to practice and get down. It's not just intuitive, or at least for
Correct.
me,
And
it's
this
not
is,
intuitive.
well, this is where I say, like, again, even if you're not having symptoms, I think just one workout a month where you can connect to your pelvic floor is important just to check in and keep, that connection with it. Those workouts can look just like a regular workout. They're just a little more mindful. So, like, let's example, take the deadlift. The deadlift is a pelvic floor exercise. And so, can I deadlift? Maybe I drop the weight by a little bit just so I can really tune in. But when my glutes and hamstrings lengthen as I go into the deadlift, into the hinge, my pelvic floor should also lengthen a little bit too. It's not dramatic, but I should get some space. So as I lower into the deadlift, my pelvic floor should also be expanding just a little bit to accommodate that force that's happening in the core. And then on the way up, as my glute, my hamstrings shorten, my pelvic floor should also shorten because it supports my spine. So when I have people who are like, well, I can't do deadlifts, they hurt my back. Okay, have we ever tried to coordinate this part? And again, I don't have a research paper that says pelvic floor contraction and relaxation affects the deadlift, but I see it every single day in clinic where I'm like, okay, we worked on all this foundational stuff. We did the sit on the hand and the breathe in, breathe out. Now, can we put that into a deadlift? Okay. And I don't want it to be forever. I don't want it to be something where every single time you go to the gym, you have to overthink, like override, or every run. Okay. When I hit my foot on the ground, I need lengthening. And when I lift up, I need contraction. That's not the point. But if I can practice it a few times, then hopefully it becomes very subconscious down the line. And now suddenly my back doesn't hurt in the deadlift anymore because I've got the support of those little muscle groups. The same way we train the rotator cuff, the same way we train, the obliques to support us, the pelvic floor does that too. So no, the lengthening and the contraction is not as dramatic as the glutes and the hamstrings, but it still matters. It's still present, it's still there. And so tying those pieces together can make a really big difference.
Wait, so for the deadlift specifically, say that again. Which going up or down are you doing the contracting in the Kegel versus reverse Kegel?
So technically, when you're going down into the deadlift, so as you're lowering into the hinge, you're getting an eccentric Kegel, right? It's lengthening the same way your glutes and your hamstrings. When you go into the hinge, they are getting longer, but you are slowly controlling that length, right? So you're going into that stretched position. You feel your glutes and your hamstrings lengthening. Your pelvic floor is also doing that. Now, again, not as dramatic, not as big of an obvious concern. But I will literally, from an external perspective, sometimes with athletes, put my hand right on the inside of their sits bone. And as they come into the deadlift, can you just give me a little length, right? Can you just, as you come down to the deadlift, can you do that gentle reverse Kegel, not push, but open? And then when you go up into the deadlift, I want to feel your muscles move away from my hand. So as your glutes and your hamstrings shorten, your pelvic floor does a little shortening too, and seeing if we can play around with that a little bit. So into the hinge would be an eccentric contraction of the pelvic floor. Coming out of the hinge to the standing position would be a concentric contraction of the pelvic floor. Um, so again, the lengthening, reverse Kegel, eccentric is all kind of actually the same thing. Just depends on how you kind of like want to phrase it.
Yeah, I'm 100% doing that this week because I do also have back pain when doing RDLs,
Uh-huh.
deadlifts, and I just thought I was getting into weightlifting and maybe my back isn't strong enough. There's so many things happening when you're starting to get into it that don't know exactly where it's coming from, but 100% know that technique matters a ton. And same thing, like I'll just lower weights and do it slower to make sure that I'm doing it right and still get an awesome workout instead of just going for max weight with bad form. So I'm going to implement that one. And then I'm curious on the running front, like when you run, or at least when I run, I don't always think about breathing, technique. I'm trying to be efficient, but I'm
Mhm.
not, it's not top of mind. And especially my pelvic floor is not top of mind. Is there anything that you would cue runners into to be more aware when actually running?
Yeah, I think it goes back ultimately to the same thing. I do not want runners to have to overthink it, but we know that sometimes we need to slow down and practice a little bit. And then, let's say you run 4 times a week, maybe once a week, you do a run where you're a little bit more conscious of what's happening at the pelvic floor. Easiest tweak is just to change posture a little bit. So watching that rib flare, like the ribs are not, especially after having babies, right? Our ribs kind of push forward. We see that rib flares having a little moment on the internet right now, so just be careful what you consume out there. But it can be problematic in that your abs attach there. And so if your abs attach there and we've got that flared out, we've got a nice long stretch across the front of the abdomen, which means we're not able to regulate pressure in the core as well. So like tucking the rib cage down, unclenching the butt cheeks. Right? We're not clenching the hips under. So let your butt relax so that it can do its job when your foot hits the ground. Those are two very easy fixes. Third very easy fix is cadence. If your cadence is really low, then you are really sticking your foot out there and demanding a lot of your pelvic floor while the pelvic floor is very stretched. So if I am asking my hamstring to do a lot of force generation in a stretched position, I'm not going to get a lot out of it. If I can increase cadence just a little bit, shorten my stride, get my foot to land fairly under my body, my pelvic floor is going to be able to absorb a lot more force there. So when you go, I mean, we all have wearables now. So if I go into my wearable data and it says my cadence is 160, well, what if I up that just by 5 to 10 beats per minute? Intuitively, feels like more work because now you're asking me to turn my feet over faster. If you can get used to that in the long term, it's so much more efficient. When you overstride, you're doing gas brakes, gas brakes, gas brakes. If you can land directly or close to directly under your body, we've got gas, 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 gas now. And so the pelvic floor has an easier time responding to that. The last thing I'll say about running that I think is an easy automatic implementation, running uphill is actually easier on the pelvic floor. It's harder on the glutes, it's harder on the hamstrings, but it's easier on the pelvic floor because you are in that little leaned forward position, right? So if I have a rib flare that I'm not aware of or don't feel like fixing or don't know how to fix, and I run uphill, I almost automatically fix my rib flare, right? Because I have to do that little lean forward. So my body's now able to manage pressure a lot better. So when I'm getting people back to running postpartum, sometimes I will have them do their jogs uphill and then walk back down the hill and then jog up, walk down, jog up, walk down. It's also why when people have leaking with running, it's often downhill running that causes problems. So when I'm running down the hill, my ribs stick out a little bit more. I don't manage pressure as well, and I'm getting that jarring force on my pelvic floor. And so using hills to your advantage to integrate a little bit more pelvic floor work, postural work is an easy way to do it without having to feel like you're bogged down by thinking about, am I contracting or relaxing or inhaling or exhaling? It's just a good way to practice for your body. And then we slowly remove that, right? So we add speed to the inclines, or we go from a 5% incline to the treadmill to a 4% to a 3% until we're ready to do flat road and then go from there. So hills are a good way to implement it without having to overthink.
Oh my gosh, I wish I had you and that advice
Same, I wish I
postpartum
had it for
because I
myself.
100% I 100% fall into that camp, and it's still to this day the only time I have a tiny amount of leak is sometimes running downhill. It's
Mhm.
wild, and I don't know when it's gonna happen or why, like, what the combo is, but I do know that it's only on a, really large, decline running, on trails going downhill, and just that hill piece. I mean, you can get such a good workout doing hill repeats and just other things out on the trails besides just running if you love running. So I wish I had that piece of advice because that is 100% me and where I'm at.
Yeah. I will also say in a case like yours where I mean, the reality is, again, running downhill is very jarring on your pelvic floor. It's a lot of work, right? You know, when you're going downhill, it's like boom, boom, boom. It's hard to absorb that force going into the ground. Because the pelvic floor is such a force absorber, it obviously suffers in that. And so it has to be incredibly resilient and mobile and strong in all forms to be able to tolerate that. So there are pelvic floor weights, which people always are like, well, what are you talking about? They're these cute little weights. One of my patients calls them their mice. So I started calling them mice. They're just little weights. They look like little eggs. Don't buy the crazy ones on Amazon. Intimate Rose is a brand that's made by a pelvic PT. It's good for your body. It's healthy. It's all the clean things you want. There's 6 of them in a pack. A lot of times I will have clients, like in your case, use a weight in the shower. So like when you get in the shower, you insert the weight. You do not stick it straight up. You're going to insert it kind of back towards your tailbone so that it rests on the hammock of your muscles. And you can do things while that weight is there. So, like calf raises, do a couple calf raises in the shower and see if you're able to hold and lift that weight. You can also tug on the weight and see, can I resist that tug, right? Can I fight against that a little bit? I think that for a long time, and still now, we have been very hesitant to prescribe weights for clients who we feel like have overactive pelvic floors. So in your case, more than likely, just knowing your activity levels, you're going downhill, your pelvic floor is overactive. So it's that exact same trampoline example. It's very jarring. And so when you hit the ground, the pelvic floor can't move. When it can't move, can't absorb force, something's got to give. If we can use the weights to teach strength, then a lot of times what happens is they stop clenching as much. So I use the phrase a lot, like strength gives permission to soften. We for so long wouldn't
Mm.
strengthen tense muscles because we were like, oh, it's tight. Why would I strengthen it? Now we realize it's not the muscle being short, it's the nervous system saying, we don't have the capacity because we're not strong enough. And so when you teach it to be stronger with something like weights, then it understands, okay, that's what you're asking of me. I can handle that. You just have to train it the same way we do everything else. So the pelvic floor weights from Intimate Rose, they're a wonderful tool. And I think they're really underutilized for athletes who are trying to do very hard things because the thought is these are only for like older women who are dealing with leaking when they're like working at a desk job or whatever. They're for very active individuals too, if we prescribe them the right way. So in a case like yours, that's something that, is something to consider. Can we add weights to the pelvic floor the same way we do all of our other muscles?
Yes, love that. And before we go, I am curious then, because you talk about weights, is there things that you see out there where you're like, absolutely not? Please do not fall for this gimmick. You see them all the time, or women trying to like use different things for, who knows what. Like any of those where you'd say, please do not use these, touch these, go
Um,
there.
the stay dry chairs. I don't know if you've seen those pop up. There's a couple different brands now. They're the ones you sit on them, and they use e-stem like a TENS unit kind of situation. Again, oversimplified, but like, if we can't get your quad to turn on in the rehab setting, we might put the little pads on your quad, make a tingle, turn on your nerve, turn on your muscle. They have those now for the pelvic floor. And so you sit in this chair, you're fully clothed, but it does it through the clothing. And the idea behind it is, oh, you do like 1,000 Kegels in a session, which sounds great on the surface. But again, like you in the weight room, would I ever give you 1,000 deadlifts? Like, never would I do that, right? That doesn't make any kind of sense. And then number two, we know that those e-stem approaches only activate what are called type 2 fibers, which are the big muscle fibers. The pelvic floor is 70% type 1. So if I just sit on this chair, it's going to activate my type 2 fibers 1,000 times, apparently, but it's only going to get about 30% of the pelvic floor. So my big thing is for people, like if you're like, Rachel, I'm not doing physical therapy, I don't want to do the weights, I'm never going to go see anyone, and I want to fix my leaking. I mean, you can try it. It's not going to be covered by insurance, so it's going to be super expensive. More than likely, the results are only going to last as long as you continue to go back and use the dang chair over and over and over. And again, you're only hitting about 30% of the pelvic floor versus if you learn to do it yourself, we can get all of it. So to me, they're just a huge cost for a very small potential benefit. If you have pelvic floor activity, it's probably actually going to make your symptoms worse. So for a lot of people, you're going to go the opposite direction. So if you go to the doctor and say, hey, I'm leaking, what could I do about this? And they hand you like a stay dry chair, flyer, run. Go to a pelvic PT instead. So don't waste your money on those unless you're like, listen, I'm not doing anything else and I have nothing left to lose at this point. Then sure. But I will also say in terms of pelvic PT, there's a lot of pelvic PTs out there who do not integrate athletic performance. So if you've tried pelvic PT, didn't get good results, and you're a very active individual but don't feel like your PT was bridging the gap between that, find someone who's more performance minded, because Kegels on a table, reverse Kegels on a table is not going to translate to trying to qualify for the Boston Marathon, right? Those are two very different goals. So you have to have someone who can get you from point A to point B, and that takes some of that orthopedic understanding. So just making sure that the person you're working with actually makes sense given your goals.
Love that. Well, Rachel, thank you so much for the time and sharing so much of your insights with us. This was awesome. I have a lot of things I'm going to do this week, so I'm very excited. If people want to learn more about you, where can they go?
Easiest place is Instagram, so at dr.rachelselman. I'm fairly active on there. I'm trying to spread my wings a little bit into Facebook and YouTube and whatnot, but truthfully, Instagram is the easiest for me. But I do respond to messages, so feel free to message me, and my email is listed on there as well if you want to work together.
Love it. And then when does your book come out again?
It will be out on October 6th, so pre-orders are open now, and as someone who's never written a book before, I had no idea how important pre-orders are. So if you search just Floor Rachel Selman, it'll pop up. You can order it through Barnes & Noble, Amazon, wherever you prefer, but pre-orders signal to the distributors like, hey, there's interest in this book, and so then they end up getting more of them, so it gets to more people. So if you are considering the book, I know the thought of like, oh, I'll just wait till it comes out in October. Go pre-order it now, because that shows the distributors, hey, people actually care about this topic and want to learn more. But you can just Google search Floor Rachel Selman and it'll all pop up.
And we'll definitely put those in the show notes. And thank you again so much.
Thank you for having me.
Thanks for listening to another episode of Find Your Fuel. If you enjoyed the show and want to support us, please leave a comment or review. And before we go, I have to give you the obligatory medical and legal disclaimer. This podcast is for informational and educational purposes only. The advice and recommendations we discuss are not intended as medical advice and do not replace the treatment or care of a physician or any other primary healthcare provider. Using the information shared today does not create a doctor-patient relationship, and it should not be used to diagnose or treat any health problem. Always consult with a qualified healthcare professional before making changes to your diet, exercise routine, or medications. The use of any information provided is solely at your own risk. So in a nutshell, let's be smart and remember these stories and conversations are for educational purposes only. Help other women find the fuel to live their best lives. We'll see you in the next episode.